Good morning. My name is Diego Mendoza. Today I'm going to talk about an interesting case that caught my attention a while ago. This is about a clinical case about a 14-year-old male with a 3-year history of repeated epistaxis, for which he went to the ENT department and the nasal endoscopy was performed. They detected a reddish tumor that was found at the level of the right middle meatus. So a CT scan was ordered. So a contrast-enhanced CT scan of the paranasal sinuses was made. The ones above are two axial contrast-enhanced CT scans, and the ones below, the one to the left, is a contrast-enhanced coronal reconstruction, and the one to the right is an axial bone window CT scan. As we can see, a lesion located in the right nasal cavity with an epicenter located in the sphenopalatine foramen. This mass is irregular, expansive, with partially defined borders, with heterogeneous density. This mass is extending towards the pterygopalatine fossa laterally, the ethmoid cells medially, sphenoid sinus, and nasopharynx posteriorly. Okay. In the bone CT, we can see that this mass is eroding the medial wall of the maxillary sinus, the anterior wall of the sphenoid sinus, as well as the greater wing and the body of the right sphenoid bone. And the coronal, we can see that this mass is displacing the right middle and inferior turbinate, as well as the nasal septum, with obliteration of the left nasal cavity. After the CT scan was made, a contrast-enhanced paranasal MRI was ordered, mostly to determine the extension of this mass to the orbit or intracranial compartments. To the left, we have an axial T2 weighted image. The one in the middle is a coronal T1 weighted image, and the one to the right is a post-contrast T1 weighted image with fat saturation. As we already saw in the CT scan, we see a mass located in the right nasal cavity, located in the sphenopalatine foramen. This mass is irregular, expansive, ill-defined, heterogeneous, with heterogeneous intensity, mainly hypointense in T2 and T1, with avid enhancement after contrast administration. This lesion, as we can see, it extends to the pterygopalatine fossa, okay, the ethmoid cells, the sphenoid sinus, and the nasopharynx. Okay, there was neither orbital nor intracranial involvement in this patient. So to treat this lesion, an embolization was made, and then a surgical resection was in order. Here's the post-op CT scan, in which we can see an axial and coronal paranasal CT scans, in which the right nasal cavity mass is no longer seen. We can see also a partial surgical absence of the nasal septum, okay, in its posterior region, as well as the right middle turbinate. So after the surgery was made, pathology confirmed this was a case of a juvenile angiofibroma. The juvenile angiofibroma, it's a rare, benign, but locally aggressive vascular tumor that originates usually in the nasal cavity. It occurs almost exclusively in adolescent males around 15 years old in average, and it usually measures from 2 to 6 centimeters. but it may become massive afterwards. The clinical presentation is typical with obstructive symptoms, epistaxis, chronic otomastoiditis due to the obstruction of the Eustachian tube. On examination, we can see a pale reddish blue mass that is very vascular, so we have to be careful because a biopsy can sometimes be fatal because of the vasculature. Speaking about the natural history and treatment, it may rarely spontaneously regress. It has a local recurrence rate with surgery from 6 to 24%. It is more common to have recurrence when it's large in size, mostly more than 6 centimeters. If the mass has intracranial spread or it has previous treatment. The treatment usually consists in surgical resection using pre-op embolization to diminish the blood loss, as well as radiation therapy. The imaging features of this pathology. Imaging plays an important role in the diagnosis because biopsies should be avoided due to the high risk of hemorrhage due to the tumor's vascular nature. This mass usually is centered in the posterior nasal cavity, arising in the sphenopalatine fossa, as we can see in this bone window CT scan. This is the sphenopalatine foramen. Okay, it usually arises from there. It extends to the nasopharynx, also to the sphenoid sinus, pterygopalatine fossa, and the masticator space, as well as the orbit or skull base. What are the CT findings in this pathology? Or in a contrast enhanced CT, we can see an heterogeneous or diffuse avid enhancement of a soft tissue mass that is located in the nasal cavity, originating from the sphenopalatine foramen. It frequently has extension to, as I mentioned earlier, to the nasopharynx or the pterygopalatine fossa, and rarely causes intracranial and orbital extension. In the bone CT, we can see a remodeling and destruction, as well as nasal cavity enlargement and in the enlargement of the pterygopalatine fossa. So here we have some examples. The first image is we can see a large vascular mass centered to the right nasal cavity. You can see the local extension. The second image is an axial contrast enhanced CT that shows a classical homogeneously enhancing juvenile angiofibroma that is originating from the sphenopalatine foramen located here. It extends medially to the nasopharynx and to the pterygopalatine fossa laterally. And lastly, we have the coronal bone CT that shows the whitening of the left sphenopalatine foramen, okay, by a juvenile angiofibroma, and also extends to the sphenoid sinus. The MRI findings are in T1 and T2. We will find an heterogeneous intermediate sinal mass. Inside the mass, we will see flow voids within the tumor. And after contrast administration, we will see intense enhancement. as we can see in the first image, an axial post-contrast T1 weighted image with fat set. We can see a left nasal cavity mass avidly enhancing that shows a few intralesional tight flow vessels. Okay. As we can see, the mass is extending to the pterygopalatine fossa. Okay. And the masticator space as well. In the next image, we have a T1 weighted image in axial shows a large left juvenile angiofibroma located in the masticator space. This mass is intermediate, has an intermediate signal intensity and multiple flow voids within the lesion. And lastly, we have a T2 weighted image infiltrating juvenile angiofibroma with a classic location, centered in the sphenopalatine foramen, extending laterally to the masticator space and medially to the nasopharynx. The angiographic findings, well, it's an intense, this tumor will have intense capillary tumor blush fed by enlarged feeding vessels, usually from the external carotid artery. And in the conventional angiography, typically will be performed before this surgery to avoid hemorrhage. Some of the differential diagnoses are rhabdomyosarcoma. This mass usually rarely affects the sphenopalatine foramen and the pterygopalatine fossa. Another differential diagnosis is the nasopharyngeal carcinoma. This mass usually affects the lateral nasopharynx and has mild enhancement. That differs the mass, the juvenile angiofibroma. Next, we have the Anthrocoinal Polyp. This mass usually affects the maxillary antrum, and the pterygopalatine fossa is not involved as well. This mass has peripheral enhancement. Okay. And lastly, we have the Estesion Neuroblastoma. Usually affects females. The mass usually is near the nasal cavity, near the cribriform plate, and it has intracranial spread. Well, this is about it. Thank you.
No, voy a ganar.
Está grabando.
Good morning, I'm Monica Huerta, and I'm going to present my interesting case. Here we have a 21-year-old female with intractable partial epilepsy, clonic movements, and also partial complex seizures that increase frequency with age. We have two images in MRI in FLAIR sequence, where we see encephalomalacia and gliosis of the right cerebral hemisphere with decreased parenchyma and dilation of the atrium and occipital horn of the ipsilateral lateral ventricle and retraction of the adjacent subarachnoid space, suggestive of a chronic ischemic vascular event, which determines a decrease in the right cerebral peduncle as evidence of Wallerian degeneration. There is also a decrease in the internal table and diploid of the entire hemicranium. Yeah, okay. Of the diploid of the entire right hemicranium associated with hyperneumatization of the frontal sinuses and also the ethmoid cells. There's also a parencephalic cyst here that occupies most of the right hemisphere, extending through the lateral fissure and displacing and compressing the adjacent brain parenchyma. And those conditions are remodeling of the internal table of the adjacent bones. On the evaluation with MR angiography, there's also a decrease in the caliber of the right internal choroid artery, and it's observed from its cervical segment and it compared with its contralateral. The absence of signal from the insular and opercular and also cortical segments of the right middle cerebral artery with dorsal disposition of the M1 segment, in addition to a decreased caliber and intensity of the signal of the segments observed. There's also, we cannot see it there, but there's also a fetal origin of the posterior cerebral arteries with decreased caliber and signal intensity of the right posterior cerebral artery, and also a decreased caliber and signal intensity of the pre-communicating segment of the left anterior cerebral artery, where we cannot see, but it's here. That makes the diagnosis of a Rasmus Encephalitis. We're gonna see first a little bit about the disease, then how to make the diagnosis, what's the treatment, and then a little conclusion. First, the disease. Rasmus encephalitis is a chronic focal or localized encephalitis. It's chronic, progressive, and unilateral brain inflammation of uncertain etiology. It's characterized by drug-resistant focal epilepsy, progressive hemiplegia, and cognitive decline. Classically considered to be a childhood encephalopathy, and it has a usual adolescent or adult onset in the variant forms. In our patient, we saw an adolescent onset, and yeah, it's one of its variants. It has 3 stages. First, a prodromal stage with which is a non-specific low seizure frequency and mild hemiplegia. The acute stage, which has frequent seizures, often epilepsia partialis continua, and progressive hemiparesis and cognitive decline. And the residual stage, which has a permanent and stable neurologic deficits and continuing seizures. The diagnosis of Rasmussen encephalitis, it's with imaging studies, and we can see a unilateral progressive cortical atrophy, as we can see in the image. Also, it's usually unilateral, predominantly frontoinsular or parietal. In our patient, we saw it complete because it had the fetal origin of the posterior circulation also, and it presents with cross-cerebral diascasis. Our best imaging tools are an MR with contrast and also a PET-CT. We can classify it with an MRI using T2 weighted images in stage 1, where we will see swelling and hyperintense signal, as you can see in the picture. The stage 2 can have a normal volume and also can present a hyperintense signal, the same that we saw on the first stage. And the stage 3 has atrophy and hyperintense signal, and stage 4 has progressive atrophy with normal sign. The differential diagnosis that we can see are Sturge-Weber syndrome. In Sturge-Weber syndrome, we also see port-wine facial nevus and enhancement of bioangioma, progressive hemispheric atrophy, and on the imaging studies, we can see cortical calcium, as we can see in the image right there. The focal cortical dysplasia, that might cause hemispheric status epilepticus, resulting in unilateral volume loss, which we can also see in Rasmussen disease. But here we can see the two layers of gray matter. Also, we can differentiate it with Dyke-Davidoff-Mason syndrome that has a unilateral brain atrophy, compensatory calvarial thickening, hyperaeration of paranasal sinuses, and it follows a in utero or perinatal infarct. The difference with Dyke-Davidoff-Mason and Rasmussen encephalitis is that here we have calvarial thickening, and in our patient we had remodelation of the bone, and some others like unilateral cerebral vasculitis, paraneoplastic syndromes, or onconeural antibodies. The treatment it has a refractory seizure, so it's refractory to anti-epileptic medication. It can have transient improvement with plasma exchange or with immunotherapy, with steroids, also B-cell and T-cell directed agents, immunomodulatory treatment, or you can also use surgery for a definitive treatment of the seizure. They make a functional hemispherectomy, central disconnection, total hemispherectomy, and yeah, the functional MRI can demonstrate the exact point of the seizure origin, so they can do that hemispherectomy. So for Rasmussen encephalitis, consider it if the patient has increasing frequency of partial complex seizures with post-ictal deficit in patients with initial normal imaging, or intractable epilepsy with progressive atrophy of one hemisphere showing with high T2 signal. And that's it. Thank you very much.
Okay. So good morning. My name is Mri Nunez. I'm a third-year-old resident from the Jose Lutero Hospital, and I'm going to present you my interesting case. Okay, so starting with the clinical case, it is a 10-year-old male patient with neck pain since 23rd of August, and it was associated with the radiculopathy in neck and right shoulder, in the dermatomes from C5 and C6. It was after a traumatic event. It's like a traumatic, but it would refer like a sister. He was playing with his sister, and she hung from his neck, and that was the event. Later, he was recovered, but the following days, he started with leg weakness and arm paresthesis. So with all this clinic, cervical and magnetic resonance was requested. So we have it right here. So starting from the T2 weighted image, the first one, we have like 3 only images here. We can see, starting from the cervical column, we can see everything's okay. We don't have nothing like ossifieds, something that are compressing the cord. But we can see that the cord that is enlargement, it has a long widened anterior posterior diameter, and we can see that there is a hyperintense in the intermedullary substance, and also we can see like an image that is hyperintense right in the C4, C5 level. And also, if you take a closer look, you can see there are like serpentine images. There are hyperintense in this sequence. We can see there in the extradural localization, more in the posterior aspect, but also in the middle of it. Here is a video. Oh, sorry, I was referring like I can move it. Can change this. Apology. Well, I was referring these images. There are serpentine images in hyperintense in T2, and this image like is in C4, C5 level. Here is a video. Let me show it. In actual imaging. That I can run. Well, let me see if I can make it slower. Okay, technical problems. So let's see. Okay. So we can see the enlargement of the cord, and over here, like C4, C5, we can see this image that is hypointense, and also we can see there are some structures. There are serpentine images, and almost here, right over there, we can see an image that is from the anterior aspect to the center of the cord. Okay. Then we have a stir imaging. This one is preferred to see if there is edema in all the gray matter, and we can see there is all way from the basilar aspect to the superior thoracic levels from the cord, and the center is more in the C4, C5 level of vertebra. And then the merge, there's a sequence that can help us to see if there is like hemosiderin rest. So there's blood products, and we can see that there is some here in C4, C5, the image that we were watching in the T2 imaging. And also we can see in the bulbar aspect, and we can conclude that it was an hematoma, and it was associated to the clinical presentation of the patient. Then we made a contrast enhancement. We have a T1 that hasn't gadolinium and the enhancement imaging. And we can see that in the level of C4, C5, we can see there is a slightly enhancement at this level. And we also requested a dynamic contrast enhancement imaging. And this one is related to injecting the gadolinium and in different time we can see the dynamic of the blood flow. So we can see if there is a how is the dynamic of the blood. And we can see how the vessels are getting brighter and are like flowing. So we can see slower here. It was very faintly, it was very discreet, but we can see that there is a posterior like a network of vessels that we can see very, very closely. Let me see. There's okay. Over there. And we can see in the posterior aspect of the cord. And finally, we have a 3D TOF. It's a time of flight imaging that we can see better the vessels of the. We use it usually in the brain, but also we can use it in the spinal. There's a sagittal imaging from side to side, and we can see a discrete vessels that are from the posterior aspect. Okay, there are these ones over there. We can see. So with all these findings, we have a differential diagnosis from a vascular malformation, and also with a slightly enhancement, we can consider intramedullary neoplasm. So it was requested an angiography to rule out this diagnosis. And we can see the first one is an injection right into the right thoracervical trunk and going to the cervical ascendant artery to the cord. And we can see this feeling of contrast that is going from the level that we saw the hematoma, but we can see now like an image of serpentine images that are filling, and the draining vessels, the veins are draining very quickly. Let me show you. And it is at the level of C4, C5, and also the engorgement of the veins that are over there. We can see it clearly. And it was a shunt right here with the radicular arteries that are filling the image that we can see. Right here we have a static imaging from the lateral view that we can see the same image, but we can see that there is an engorgement of the draining veins here and all the vessels that are. The important thing is that they are around the cord. They are not inside of the cord. And also we have another static imaging from another supplying vessels that are going to the lesion. This one is the left vertebral artery that is going a vessel supplying that lesion, and also the left intercostal artery. These ones, it was injected right into the aortic branch, and it was going right into the lesions over there, all the way up to this place. Okay, so with all the findings, it was diagnosed with a spinal dural arteriovenous fistula, and it's called a type 1 malformation, vascular malformation from the spinal aspect. and we're going to talk about it later. But the treatment, once we are in the angiography, we can make an embolization of the lesion. But the important thing from spinal dural arteriovenous fistula is that the material is a liquid polymer that it has to go right through the artery and go into the vein. It has to pass the artery to stop in the vein, so it closes the flow and the lesion is all recovered. In this case, I have this video before the embolization and after that we can see that feeling and some material that is going through the right cervical ascendant artery to the radicular arteries and right to the lesion. You can see it over there. And now you can see how the lesion is almost completely disappeared. And in this moment, the patient was monitored with like an electroencephalography to see if he was responding to the treatment. So if he didn't start moving or the impulse were going down, the embolization was stopped. But if he was continuing with his neural signals, they can continue to the embolization and to see that they weren't damaging anything of the cord or the neural stimulus. Right there. Okay. This is a video from the patient that I requested with the permission of his and his father. So we can see how was the impairment of the movement of his arms. He only could move his arms, not up to his head, and he couldn't even move his legs. He had also like sensitive impairment from all his extremities, but we can see he only can make like slightly movements of his arms. Okay, so with the diagnosis, there are spinal arteriovenous malformations, and we have 4 types. We have type 1, that is the present case. It's a dural arteriovenous fistula that is the most frequent, up to 80% of all the malformations. And this one is extradural and extramedullary. There is a connection between the radicular arteries right to the venous draining veins, and they're not going with capillary vessels. So it's a fistula, but it is outside of the cord. The type 2 is called also glomus type or a plexiform. This one is intramedullary. It's only intramedullary, and there's also an engorgement of the veins that is a malformation draining. The type 3 is a juvenile type. It's like a 7% of the cases, and it is a large, complex intramedullary and also an extramedullary malformation with multiple feeding vessels that are going from radiculary or from the anterior spinal artery. And the type 4 is a perimedullary fistula that is not inside the cord, it's only outside and is around it, and also has the engorgement of the veins. It is most common that is ventral, but it can also be dorsal. In our case, it is a spinal dural arteriovenous fistula. Is the most frequent. It is 70 to 80% of the cases, and the age is usually presented in the 5th or the 6th decades. The range is 20 to 80 years old. Actually, there isn't any report of a younger patient from 20 years old, so it could be the first one that is reported. this one. The signs and symptoms, it is almost presenting in the first with lower extremity weakness and exacerbated by exercise. In the imaging, we can see with the T2 or stereo imaging, we can see the edema of the cord represented by a hyperintensity. We can see also perimedullary vessels dilated with flow voids that they are hyperintense in the imaging, like we can see in the first image. Here we can see image that are serpentine and hyperintense in this sequence. With the T1 enhancement, we can see there's a faint to moderate parenchymal enhancement. So this makes us the differential diagnosis with the tumor. There's a difference between the T2 and stereo imaging and T2 more heavy weighted imaging. That is like a Fiesta. And we can see in the stereo imaging more the edema is more conspicuous, and in the Fiesta we can see better the vessels that are around in the canal, medullary canal. With the dynamic contrast enhancement magnetic resonance angiography, we can look for the abnormal core surface vessels. And we can define the site of the fistula. That is very helpful when you're making the angiography to take less time to the study and going through directly to the site of the fistula. And also, it can guide to the catheter angiography. With angiography, that is the gold standard to diagnose this lesion. We can identify the exact level of the AV shunt. There is here in the T9 vertebral level, and you can precise the locations of the anterior spinal artery. That is important to look for other supplies arteries. And the other thing is it can be like a therapy with the interventional embolization with the particles that I told you. And with only embolization, you can recover all the patient. In the differential diagnosis, you have to rule out first the other types of vascular malformations, and also you have to rule out an intramedullary neoplasm. And the most important you have to consider is an ependymoma. That is a neoplasm that it is arising from the ependyma lining spinal cord in the central canal. You can see in the T1 weighted imaging like an isointense or slightly hypointense to spinal cord. In the T2 weighted imaging, you can see it like a hyperintense relative to spinal cord. And you can see a capsine that is an hemosiderin of cranial or caudal margins, like you can see in this one. It is a capsine. And with the enhancement, you can see a slightly enhanced of these lesions. And like an ependymoma, you can consider like astrocytoma. There are more frequently, but less conspicuous like this one. And that's all. Thank you very much. So,
Good morning. My name is Carla Reina de la Garza. I'm also a third-year resident, and I will be presenting my interesting case. Let's begin with some information from the patient. She's a 19-year-old female patient with no non-medical history of relevance. On July 16, she began with hereditary hallucinations, which were accompanied by one episode of headache and epistaxis, which resolved without any treatment. On July 23rd, she had a sudden onset of irrational fear, as well as nausea. Her family referred that fear as something that caused her a lot of anxiety. She referred to fear of losing her friends, losing her family. She was seen by a general physician in a pharmacy consult, and her episode was treated as an asthmatic crisis, even though the patient hadn't referred any history of that diagnosis. So she was just treated as that, and she was sent home. But her family decided to take her to a local hospital where she began on the same day of July 23rd. She began with presenting seizures, as well as visual hallucinations. That happened within the hospital that her family took her to. She was then referred to a third-level hospital where she presented with more visual hallucinations, and she was treated with an apparent drug intoxication, even though, again, she hadn't ever referred to any consumption of any illegal substance, and her family denied the possibility of such a diagnosis. But that was the way she was treated, and she was discharged. On July 25, she began with an altered state of consciousness, which now had also memory loss of short memory. And she also began having a fever of over 100 Fahrenheit. Because of that, she was taken to another clinic where her family decided to take her to a clinic here in the state of Nuevo León. Originally, she wasn't in this state. She was treated elsewhere, but she was taken here by her family to a clinic where once again, she was diagnosed with drug abuse, intoxication, and she was discharged. Her family decided to take her to our hospital, not being satisfied with the treatment the previous physicians had given her. So they took her here, and she was approached as a possible encephalitis by the physicians at the ER department. So what are the symptoms that we can have on encephalitis? We already saw one case of encephalitis today, but this is a different type of presentation. We have a very young patient with a very onset presentation of their symptoms. And though a clinical presentation in encephalitis can be very varied, a lot of patients will start with a short prodrome that mostly consists of headaches, which in our patient was present. And the most common symptoms of a patient with encephalitis can be of psychiatric nature, such as agitation, confusion, hallucinations, and strange distributed behavior. But also cognitive symptoms can also be present, like short-term memory loss, which our patient also presented. And later on in the disease, in later stages, we can have motor dysfunction, such as seizures and disconnected facial movements. Our patient also had seizures. And in the latter stages of this disease, we can also have autonomic instability, such as hypotension, hypoventilation, and cardiac dysrhythmias, among others. And these symptoms usually will land the patient in an intensive care unit. So having the suspicion of an encephalitis, she was sent to get a non-enhanced CT scan on the 26th of August here in our hospital. And I just showed 3 images to represent the study. the CT scan came back as normal. There wasn't any very visible alterations that we can see. So it was reported as normal, and it was suggested that an MRI would help us better understand the symptoms of the patient, and we could have a better diagnosis. Also, the patient had a spinal fluid test, which was the first test of the spinal fluid that she had, because the physicians were also thinking that she could have a neuroinfection. And here are the results. We can see that the proteins are higher than they should be. And also we have a white blood cell count that is abnormal. But the glucose is within the normal ranges, so that basically rules us out bacterial meningitis. After that, an encephalogram was also performed, and in the report they showed that she had theta brainwaves with absence of any epileptogenic areas. This happened 2 days after she was admitted into our hospital. And well, the theta brainwaves are the ones that are present during drowsiness and the early stages of sleep in adults. And the focal theta activity during awake stages can give us a suggestion of a dysfunctional brain. Posterior to the realization of this electroencephalogram, the patient began with ventilatory dysfunction, and an intubation had to be performed. She was then admitted into the intensive care unit here in our hospital, and treatment with antivirals was began with the suspicion that her encephalitis had a viral origin. But also, one of the other suspected diagnoses was an encephalitis that was autoimmune. So here we have the APE2 score, which is a score that is performed with clinical and also laboratory results to help us guide the diagnosis into an antibody presence in the epilepsy. So here we have all the criteria that we can have. In some cases, the criteria will give us 1 point. In other cases, it will give us 2 points. And our patient had new onset, rapidly progressive mental status changes or seizures within 1 year of evaluation. Well, our patient had them within less than a month. So that's 1 point. And also she had new onset automatic dysfunction, such as level blood pressure, hyperhidrosis, asystole, and all these other examples. Our patient had hypotension, and she also had hypoventilation, so that's another point. She had neuropsychiatric symptoms such as agitation, aggression, psychosis, and emotional liability. So that's another point. We have 3. And she also had cerebrospinal fluid inflammation to manifest over 50 milligrams per deciliter of proteins or a higher white blood count of 5 cells. So in summation, our patient had 5 points in the APE2 score, and we can, in the literature says that over 4 points in this score has a sensitivity and a specificity of 82.6 to 82% respectively, to have an autoimmune origin in the encephalitis. So, because having the test to look for the antibodies in the spinal fluid is a bit more difficult because it has to be done in a center outside of our hospital. A CT was performed to look for something additional that could guide us in the diagnosis. And here I have 2 images of the contrast enhanced CT, which was performed on the 18th of August. And here we have an axial image. We have an axial image and at the level of the pelvis, and we also have a coronal reconstruction. And we can see here an image that is it's round and it has a very heterogeneous density. We have a fluid density, we have calcium density, and we also have fat density. We can also see it here in the coronal image. And here is an amplified cut, so we can see all the different densities that we can see. We have the liquid, we have fat, and we have calcium. And with these the findings, is very characteristic of a teratoma. And well, teratomas are very commonly associated with an autoimmune encephalitis. So this helps us more with the diagnosis. We didn't have the antibodies, but we had a finding that was very commonly related to this origin of the encephalitis. So an MRI was performed on the next day. Here we have 4 images on FLAIR, and we can see white matter hyperintensity here. We can also see this round image that is hyperintense. It's on the frontal lobe. On a lower cut, we have more white matter in hyperintensity. In the more parietal aspect of the brain. On a lower cut, we have another round hyperintense lesion that is on the parieto-occipital region. And on a lower cut, we have more white matter hyperintensity and another lesion here on the temporal lobe. We have the SWAN images here. We have the exact same cuts that I showed in the slide before this one, but these are all in the SWAN sequence. And we can see here that in all the areas where there was a hyperintensity in the white matter, we can see small round hypointensities that are compatible with microhemorrhages, as well as in the lesions that were more focal and that were more hyperintense in the FLAIR sequence. Here we can see how they have they are still hyperintense, and they have like a hypointense ring, all of them. So this could be compatible with a hematoma. So in this case, we have microhemorrhages and 3 focal hematomas, which are not very common findings on autoimmune encephalitis. And here we have the constant enhanced T1 weighted images, again, all the same at the same levels. And we see that all the focal images are slightly enhancing on the periphery. But other than that, we don't have any other type findings that we can think about meningitis or another type of encephalitis, like enhancement of the meninges or enhancement of the ventricles. So what are the classic imaging findings that we can have in an autoimmune encephalitis? It is said that around 70% of all patients with autoimmune encephalitis will have a normal MRI scan. But the most classic findings we can have are temporal lobe hyperintensity and hippocampal atrophy. In the case of our patients, she had hyperintensity that was in the white matter, and it was diffuse. And it was due to the edema that the microhemorrhages were causing, not in the rest of the cases that we can see in autoimmune encephalitis, when we can see that the hypointensity is more focal. Another finding is also hyperintensity in the brainstem, and in our patient that wasn't present. So we have a patient that had the specific clinic presentation about an autoimmune encephalitis. She also had the teratoma that is very associated with that diagnosis, but she had very frequent imaging findings in the MRI. It's still with that, with all those findings that we can have, even if the MRI was very infrequent with the findings,
she began with a treatment guided to the autoimmune encephalitis, which was immunoglobulin. The first dose was given to her on the 6th of September, which was like a month and a half after her symptoms presented at first. After the first few doses, she had a mild improvement, but so she was discharged from the intensive care unit, and she remained on the hospital, but she was no longer in the ICU. On the 17th of September, she began with a fever, and a blood culture was performed with gram-positive COSI. On the 24th of September, she began with ventilatory distress. She had never been able to come out of the intubation, and the bronchial fluid came back with Acinetobacter. So she was given treatment for a pneumonia, but 2 days later, her ventilatory distress became worse. She had cardiac arrest, and she had heart failure. CPR was performed twice, but on the second time, she couldn't come out of the heart failure, and she was presumed dead on that evening. So the final diagnosis came back with an autoimmune anti-NMDA encephalitis. The cerebrospinal fluid came back with the antibodies for the NMDA. So that confirmed the diagnosis, even if the treatment had begun making an improvement. The treatment was administered to her very late, because it was getting to that diagnosis took a long time. So she was given the treatment in a very late stage, that it was the encephalitis was already it had already caused a lot of autoimmune automatic problems for her. So these are the references that I use for this case, and that's it.